Okay. So I've asked Dr. Woodhouse to come speak about maintaining your body and maintaining your temple. Part of it was to health maintenance. So as we go through different stages of life, there's things that we can do to keep ourselves healthy. And that's kind of the idea. So I've asked him to come speak about it. He does have a handout for you at the end. He'll give it to you. He didn't want to let all the thunder out, I think. I'm guessing on that one, but you know, I think that's how that works. So I'll have, and Dr. Woodhouse has been, you've been here since 90-something? 94? He's been here since 1994. And I know, I've been here longer than that. But he works at ISU Family Medicine, and you're one of the doctors that take residents around with you and train the newbies. So he trains a lot of the newbies. And anyway, he has a wealth of knowledge, and I'm thankful for his willingness to share it with us. So, if you have anything else to say about yourself, you're welcome. No. Do you want to push the button? You'll control it? Okay. So then I'll go back to the camera.
So, I'm going to talk a little bit about maintaining the temple, and I think that when Paul talked about the temple, this is what he had in mind, because this thing was still standing as far as I can tell when he wrote what he wrote. And what he wrote is you do you not know that your bodies are temples of the Holy Spirit who is in you, whom you have received from God. You are not your own. You were bought with Christ, therefore honor God with your bodies. From 1 Corinthians. What we're going to talk about is what it means to maintain this temple, to make our bodies last and work well so that we can serve others and do everything else that we need to do in our lives. And for some, and also to thereby take a look at how we view not just our own health, but how we view health care and what this commodity of health care that really permeates our society. Just try to sit through any NCIS without seeing 12 commercials about new medications. You know, health care is very, very big business. And what it has to offer is not always what people think it offers. And so we'll talk about our healthcare system a little bit. So we're going to start out by asking a very simple question. First of all, who here thinks that you're healthy? Okay. I want you to think about that idea of healthy. And for those that raise their hand, I want you to start thinking about what is it about you that says, yep, that's health. And for those that didn't, what's missing? What isn't there? Because we're going to actually ask that very simple question. What is health? And if we're going to do health care, then whatever we do in our healthcare system should try to achieve that thing that we call health, right? You would think. Maybe. We're going to ask the question, okay, now that we know what health is or have some sort of consensus with that, why do some people live sicker and die earlier than other people? What are the driving forces there? And I used to use the phrase bad habits when somebody would ask me, why did this happen to me? You know, why did I get whatever disease A or B or whatever? And I says, well, diseases are divided between bad habits, bad genes, and bad luck. And usually some combination of the above. You can have a genetic tendency that's expressed because of a bad habit that you have. You can have bad luck that just comes out of the blue regardless of all the above. Once we discuss that a little bit, of course the next question is, well, how do I live a longer and healthier life? Okay? And I think it's very important that there always be an and here. That I not only want to live a long time, but I want to feel well the whole time I'm alive. That's what most people want. And then finally, talk a little bit about what our healthcare system is for, what it does, what we need to ask it to do, so that we get what we want out of it. So, Somebody tell me what healthy means. Oh, this is a scene from Monty Python and the Holy Grail, where they're asking him to bring out their dead. And if you remember this scene, for those that have seen it, the guy says, "I'm not dead yet. In fact, I'm feeling pretty good. You should put me back where you found me. I really." And then they knock him out and put him in the wagon anyway. So what does healthy mean? How do you know you're healthy?
Above ground?
Okay, you're alive. You got a pulse. Okay, is that it? Everybody with a pulse is healthy. You know that's all there. That's one view. That's one view. I'm not dead yet. Okay, that's this guy's idea. What does healthy mean?
Well, to me, it means waking up in the morning and feeling just wonderful and excited about the day that's ahead of us, and
All right. So it's feeling like you can do what you want to
God
do.
has a lot in store for us.
Okay. So it's looking forward to things. What else? What's health? I'll never forget a guy who I do a little cross-country ski racing, and this guy that got done with this race, and he was telling me about what a horrible race he had and how bad he felt, and he was worried about whether he might be getting sick and whether he overtrained and all this stuff. And of course he beat me by half an hour. And this guy does not feel healthy. If you asked him, he'd say, "I'm just not feeling very healthy at all." And yet he's just done something that maybe 0.1% of the population can do. But his definition of healthy was that. What else is healthy?
Would be the absence of disease?
Okay, that's another idea, that you're not sick. So we got, I'm not dead, I'm not sick, I'm not perfect. That's another view. I feel like going on with life and enjoying life. What else could it mean?
Lack of pain, maybe?
Okay, I don't have symptoms.
Yeah.
I feel good. I have an absence of bad symptoms. What else is healthy? It's very individual. People have their own kind of set point in their head as to what they call healthy. I'll never forget a guy in my office who I had just gotten through the intensive care unit, inch of his life stuff, on the ventilator for a while, and I couldn't believe when he got in. He comes back to my office. He's on about 6 or 8 meds, and he's really, still short of breath, still having all this trouble. I said, "How you feeling?" And his answer was, "I feel great." Because compared to what he was dealing with before, he was much better off. So again, it was individual. He considered himself to be pretty healthy right then, relative.
Is it attitude too?
Well, it can be. Yeah, like it's your perspective.
Yeah.
Well, so for some people, it's just, I'm not sick. I don't have a cold. I don't have, nothing's hurting right now. I don't have any other illnesses that I know of. I feel normal. So I'm just not sick. That's enough. That's healthy. I have no symptoms of illness. I'm free of all the things that might indicate that I'm sick. So as long as I don't have illness, then I'm healthy. Everything else is healthy if you don't have illness. Okay? Which for our guy who was the athlete wasn't true at all. He actually set his mark much different, in a much different place. My medicines are working. That was my guy. He says, "I feel great because everything that I've done has worked. The antibiotics have worked. The medicines for my heart have worked. The medicines for my kidneys have worked. All these things are working, so I'm feeling great." He thought, "I'm responding to therapy, so I'm healthy now." For some people, it's a standard of, "I feel strong and energetic." Talking about you looking forward to the day. Okay? Or, "I am not dead yet." Well, what if you ask World Health Organization? What would they tell you? It's a little different. They define health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infection. It sets a different standard, okay, for what we consider health. And not one which is necessarily what's dealt with in our healthcare system. So let's look a little bit at our healthcare system and what it does every day. So in this box is 1,000 average people, okay? Now, if you take the 1,000 average people, during any 1 month, 800 will report symptoms when you get them a survey asking, do you itch, do you hurt, do you have diarrhea, do you have sore, whatever, or any other symptoms. If you give somebody a thorough questionnaire, 800 will report symptoms in any given month. So most people, 4 out of 5. A third of them will think about actually going and seeing a doctor about those symptoms. In other words, symptoms will be bad enough or interfere enough with their life where they'll go see a doctor. And actually, 2 out of 10, 1 out of 5, will actually go to a doctor about whatever symptoms or whatever condition they have. Half of those will go to a primary care physician's office, okay? Family doc, OB-GYN, internist, that kind of thing. 21 will go to some sort of hospital outpatient clinic where it's outpatient surgery. That's 21 out of 1,000 in any month. Outpatient surgery, any other outpatient clinic at the hospital. 14 will require some sort of home health care out of 1,000. 13 will go to an emergency department, so only, that'd be what? That'd be about 1 out of 100 will go to an emergency room. 8 are hospitalized. 1 might actually end up, less than 1 will end up in some sort of an academic medical center with a high level of intensive care. The reason I show you this is we have a healthcare system, and it spends almost all the money right down here. Almost all the money is spent for this group of people. Which begs the question, is there anything that could be done out here that might change how often you end up down in that corner? This is the most common causes of death in the United States according to the Center for Disease Control. By the way, you'll have to forgive me, I'm a data-driven guy, so you're going to see some data tonight. And hopefully it'll fit and make sense of what we're doing. So more people die. In other words, immediate cause of death. What's wrong with them at the time they die? Heart disease, cancer, chronic lung disease, accidents, stroke, Alzheimer's, diabetes, influenza, pneumonia, kidney failure, suicide. Yes?
Well, actually, I just heard on the news the other day that now the number 3 cause of death in the country behind heart disease and cancer is medical errors.
Yeah, that's an interesting statistic that we could do a whole talk on where they get that number.
Yeah.
But, yeah, we could, like I said, a whole other talk on what that data means. What they mean is that if they look at the health care of everybody who ends up dying, if you look back, you will find at least one, quote, medical error in their care, which may or may not have anything to do with why they died.
Oh. That's misleading then, the way
That's
It is
what I
very
told
misleading.
him. I said,
It's
that-
very
that prob-
misleading.
That probably lumps in all the times that the meds were late.
Right. And
Yeah.
I guarantee you, if you look at any patient that I've taken care of who's been in the ICU and in the floor and all this stuff, you're going to find at least one error. I promise you. It's just too complex. It's not manageable. So we've got this list of things that people die of. And the image of healthcare is that our job is to prevent those things, to make them not happen. Okay? And we have a healthcare system that does that. For instance, oh, there we go. Come on. Wake up. There we go. Oh, sorry. So, for heart disease, we've got cath labs and cardiovascular operating rooms. We've got really expensive medicines called thrombolytics. We've got coronary care units. We got treadmills. We got heart imaging. We got all kinds of stuff. It's common disease. We got a lot of these machines. We do a lot of this stuff. Okay. For cancer, we've got radiation and chemo. We've got all kinds of fancy imaging like PET scanners. We got bone marrow transplants that cost $500,000 a crack. we've got everything focused at that cause of death. We're going to prevent that cause of death. For our chronic lung patients, we have ICUs and ventilators and all kinds of home respiratory therapy stuff and inhalers that cost $300 a month. And for accidents, we have life flight and operating rooms and ICUs and trauma teams. And for stroke, we have now thrombolytics, interventional radiology, rehab. We've got home health nursing and all kinds of nursing facilities. We've got all the medications for diabetes. We've got lasers for their eye problems. We've got wound care for their foot problems. We've got for influenza, pneumonia, medicine floors, ICUs, ventilators, oxygen for kidney failure. We've got dialysis, transplants units for suicide. We've got behavioral health units, all kinds of expensive medications. And ECT, electroconvulsive therapy, if you get that bad. So when you look at this list, you almost describe a hospital, don't you? And it's all aimed at preventing the causes of death, which on the surface sounds pretty reasonable. Now, there are some problems with this approach. Come on, you can do this.
Sometimes it's slow.
What we have is a fire department for our bodies. When we catch fire, catch pneumonia, catch cancer, catch whatever, we get a heart attack or whatever, we have people who come and put our illness out. Okay? That's what our system's for. That's what the hospital's for. That's how we view it. When you look at, see the commercials on the TV, they want you to come and get the latest and best and most technically sophisticated treatment for your prostate cancer or for your esophagus problems or the list goes on and on and on. We want to put that fire out and prevent that cause of death. Come on. It's thinking. Probably the best example we have of this is, if you remember the Ebola epidemic, where we have this disease, Ebola, which is a nasty, nasty disease. I have no question that catching Ebola is a negative event, but all of that expense and bother and moon suits and processes and all the rest were to prevent what turned out to be 1 death and 3 illnesses with survival in the United States. We spent billions of dollars on that. And this guy, of course, is worried about Ebola, but he's not worried about the fact that alcohol causes 88,000 deaths each year, tobacco 450,000 deaths a year, and obesity 300,000 deaths per year. So he's worried about the 1 death a year by the unknown, the scary disease. And yet he continues with a lifestyle which actually is putting him at much greater risk than going and giving the guy with Ebola a big hug. So, this approach costs an awful lot of money. That's one of the biggest disadvantages. In fact, last year it was over $3 trillion a year. Now, I have troubles with trillion, okay? I can do 1,000. I have a pretty good idea what 1,000 is. I can do 100,000 because I've been in a stadium where there were 100,000 people and I know how many people that is. I can pretty much do 1 million, okay? I kind of get my head around that. I have trouble with 1 billion. Billion's hard. And 1 trillion is totally out there. So, somebody explained to me what 1 trillion is, and it makes sense. It's 3 with 12 zeros after it, okay? And so, how do you explain 1 trillion? Well, you explain it this way. Take something really, really small, okay? A second. A second's really small, right? 1/1000, that's a second, right? Let's take 1 trillion seconds, okay? Let's go back in time 1 trillion seconds. When was that? Any guesses? How long ago was 1 trillion seconds? What happened 1 trillion seconds ago? Anybody make some guesses?
Dinosaur.
Dinosaurs, okay, pretty close. Yeah, it was like 2 ice ages ago in seconds. And for each one of those clicks on the clock, since, 2 ice ages ago, we've spent $1 every year, $3 every year, every one of those seconds last year. Okay, it's a lot of money by any estimation. It's an enormous amount of money. In fact, we spend. The problem with that is, though, it'd be nice if, I'd be okay with that if we actually got this really great health system that actually did what we thought health systems should do. But the fact is, we don't get what we pay for. I wonder if this is how else. Let's try that. So this is more data. I apologize. And down here is how much each of these countries spend on healthcare in a year per person. This isn't total, this is just each person. So if you go to Switzerland, they spend about $3,000 every year. Go to Sweden, about $2,200 a month. This is a couple years old, so this is probably a little behind. Japan, and all the rest. Over here is healthy life expectancy. Not just how long you'll live, but how long you'll be healthy before you die. And of course, Japan does really well, Sweden does well, Switzerland does really well, and this is where you pay. This is what you pay to get that. And these are all the rest of the OECD countries. These are Organizations for Economic Cooperation and Development. These are the places where you can drink the water and walk the streets in the world, okay? They are the first world, okay? So any guesses? By the way, there's only 21 diamonds here. The 22nd country is the US.
Yeah.
Okay. Wait for it. We spend twice as much as everybody else, and we are below or at the level of everybody as far as healthy life expectancy. Okay? Disconnect, right? So, we don't accept this in other areas of our lives, by the way. We take a different approach. You know, we had this picture of fires being fought, and we don't wait for buildings to burn down. We build buildings differently so that they don't burn down. We have uniform building codes that make buildings harder to build down. That's why all the doors fall shut whenever the fire alarm goes off. That's why the doors are made of certain materials, why you can shut off certain parts of buildings. It's to keep buildings from burning down. We build different buildings, and actually we'd have a lot more fires. Anybody who knows anything about the major fires that swept through the major cities in our country 100 or 200 years ago know that it's a very different environment, and it's not because we put out fires better. It's because we have buildings that are harder to burn down, and we have electrical standards where you have to put in wiring in this very specific way, and they inspect it to make sure it's put in that way before they close out your walls, or they'll make you tear your walls out and they'll look at the wiring for you, okay? We don't accept this in buildings. Yet we wait for patients to burn down with our healthcare system, okay? It's different. Wake up. So, a man sits by the river. And he looks out on the river, he's having a wonderful day, it's a very nice day. And pretty soon a man floats by in the river, and he's drowning. And so he gets up and he swims out and he grabs the guy and he swims back in and gets him to shore and sits down on the bank of the river again. About a few minutes later, another person goes by, and he's drowning. Gets up, gets in the river, swims out, gets him, pulls him back. And this goes on like this again and again and again for an hour or two, and finally he says, to heck with this. I'm going to find out why all these people are getting in the river. So he goes upstream. And what he finds is the bridge is out. And people are trying to get across, they've fallen in the river, and he has to fish them out. So what does he do? He puts up a sign. The bridge is out. He goes upstream of the problem and finds out why, and does something to keep people from becoming the problem that he was dealing with. Well, there are people who do this with healthcare. they look at things, and I'll talk you through this. I know the text is small. But they have a thing called risk factors. Risk factors are things that make you more likely to get a disease. The fact is, I could take a group of 100 people and with reasonable assuredness predict who's going to get a lot of diseases by asking them some very simple questions. Okay? Because certain people with certain risk factors, some they can control, some they can't, are more prone to get some diseases than other folks. So let's look at this. This is all countries, right? And they have it divided between high-income countries, middle-income, and low-income countries. We'll talk about that in a minute. But if you wanted to do one thing for everybody in the world to prevent the most deaths, because these are leading risk factors for death, you would get rid of high blood pressure, you'd get rid of smoking, you'd control high blood glucose, you'd get people more active, you would have them control their weight, you would have their cholesterol under control, you would keep them from having unsafe sex, you would cut down on their alcohol use, and on and on and on. Some of these things are things that aren't very common here. You'll notice there's no dark blue here. Indoor smoke from solid fuels, people who have to burn wood inside their houses in order to cook. It's a really big deal. And they get diseases related to it. Unsafe water, sanitation, and hygiene. You notice there's no dark blue. So, if I wanted to make as many people sick in this town as possible, and all I got to do was shoot one guy, who would I shoot? The guy who runs the water treatment program. By far. Okay? That guy prevents more disease than I will ever prevent in my entire career almost every day. Next, the guy who does sewage treatment. These guys are true heroes. They really are what keeps us healthy. If you really look at the statistics, that's what makes the biggest difference. I'd increase your intake of fruit and vegetables. I would encourage breastfeeding. Again, no dark blue here, but in other countries that's a big deal as far as passing on immunity and preventing illness from the contaminated water that's used to mix with formulas in third world and second world countries. Occupational risks, so OSHA and all that, you'll notice very little of that because there's OSHA here. Occupational safety and health, we have that protecting us, but in other countries, look at the conditions in second world countries like Mexico. Vitamin A deficiency, very strange that that's a common problem around the world. Not here, but around the world. Zinc deficiency, you never hear of that here, right? No dark blue. Unsafe healthcare injections, people reusing needles. Iron deficiency, no dark blue here. But these are causes of death. Now, realize that what's the difference between 3-week-old getting diarrhea and dehydration and dying, which is one of the most common causes of death on Earth, and an 88-year-old dropping dead from a heart attack? What's the major difference? How much life is lost? 88 years versus maybe 5 or 10 years. It's a different problem. So different health problems have different impact at different times in life. So they actually have a different statistic for us to look at that I think is more meaningful. If it will switch. Come on. It's called disability adjusted life years. This is another World Health Organization thing. And this is a common currency by which deaths at different ages and disability may be measured. For instance, somebody gets chronic obstructive lung disease, and for the last 12 years of their life, and when they're 67, and for the last 12 years of life until they die at 79 of pneumonia, they're on oxygen and they can't walk across the room very well, and they can't get up and down the stairs. With a disability adjusted life year, they look at that as really what we're looking for is how long are we vigorous and feel well and want to do things that we want to do, not until we're chronically ill. that's taken into advantage here. So one daily can be thought of as one lost year of healthy life. So that's really what people want. They want to feel well. You know, we talk about this concept called squaring the curve, which is, I want to be really, 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 really healthy and then die. Okay? You know, it can go on for as long as it wants, but whatever it decides, okay, I'm there, okay, take a good shot, right? And the burden of disease can be thought of as a measurement of the gap between current health status and an ideal situation where everyone lives into old age, free of disease and disability, and then dies. There have been literally billions of attempts to live past 120. They all failed, as best we can tell, in current times. We have no recent recordings of anybody living past 120 in current life. I don't plan on living past 120. Something's going to happen before then. Okay? That's just true as best I can tell with everything I know about what happens now. We can talk all we want about what used to happen, but right now that seems to be true. Sorry, this is pausing. There we go. Okay. So this is looking at disability adjusted life year. Oh, jeez. No, it works too well.
Yeah, if you press twice, again.
Okay. So this is looking at a different statistic. This is disability adjusted life years attributed to 9 leading risk factors by country and income level. So if you want to have the greatest impact on how long and healthy people are in the world, you feed moms, pregnant moms in third world nations, by far. Greatest impact on lifespan and enjoyment of life total. You distribute condoms so that to prevent sexually transmitted disease. In second world nations, you take care of alcohol abuse, unsafe water, sanitation, and hygiene. In third world nation, so while you're feeding the moms, handing out the condoms, you make sure they have clean water. Okay? Big bang for the buck. Huge response to your efforts. You get into second and first world nations, you got to start talking about tobacco use. And you realize, everybody's seen the cartoons about first world problems, you know? Like, what's a first world problem that everybody knows about?
I had to make 2 trips with my grocery bags.
That's right, yes, I had to go back and it took me 2 trips to bring my groceries in. That's a first world problem, okay? You give them a little cooking stove so that they don't have to burn fossil fuels inside their homes and poison their lungs. These are really low-hanging fruit as far as cost for a lot of these places. But it's a lot less safe. Younger people die more in third world nations. And then we go on through, but rather than look at that, let's look at a little different perspective then. Again, I apologize, I am kind of data-driven. But this is where it's broken down by different nations. So this is what you just saw before. If you wanted to go worldwide, 10 leading risk factors, causes of death by income group. You look at high blood pressure, tobacco use, blood glucose, physical inactivity, overweight and obesity, high cholesterol, unsafe sex. Well, let's look at our country. By far, and I can write a prescription for anything I want, I can arrange any surgery you want. If I can convince one of my patients that it's in their best interest to quit smoking, and they quit smoking, it has a greater impact than any prescription I have ever written, every single time. There's no contest here. We have this idea, statistical thing called treatment size effect, which means, okay, I've got this treatment here that brings cholesterol down a bit, okay? But really what I want to know is how many fewer heart attacks and strokes do people get? And I might get a few fewer heart attacks, a few fewer strokes. If I get them to quit smoking, the difference is this big. It's a factor of 10 or more. If I get them to exercise regularly, it is a far greater effect than most of the other prescriptions I write for high blood pressure, for cholesterol, and all the rest. So when you look at treatment size effect, the things you do every day matter more than the pills you take. That doesn't mean that the pills don't matter, because clearly our blood pressure medicines have clearly been shown to extend people's lives and prevent plenty of strokes and all the rest. But if you go past the opportunities for lifestyle change, you are actually walking away from the most important part of the therapy. When physicians recommend that lifestyle change occur, it isn't because we're moralistic people who would rather not bother with writing you a prescription. It's because we're offering you the good stuff up front that actually works better. Okay? So in our country, tobacco use, your blood pressure must be controlled. Okay? You must look at weight and diet. You must be physically active if you expect to feel healthy. If you really want to feel well, it's got to be part of the equation. You've got to have control of blood sugars. You've got to have control of cholesterol. Now, one thing you'll notice is, here's high blood pressure, high blood glucose, and high cholesterol. Now, the first thing you think about, well, is we're going to take pills, right? Or give insulin injections. Well, no. Remember, one of the most effective ways to bring blood pressure down, decrease blood glucose, and to decrease cholesterol is physical activity and weight control. By far. Far more potent than the pills that are given to get those things under control. Do the pills matter? Yes, they matter. I'm not telling you to stop taking them. What I'm telling you is if you're doing just them, you're leaving the good stuff on the shelf. Okay? When we talk about fruit and vegetable intake, air pollution, something we can't do for a lot of patients. They're stuck living where they're living. Decreasing alcohol use and avoiding occupational risks. When you live in a third world country or a first world country, this is your list. Why? Because the guy who runs the water treatment plant shows up every morning. The guy who runs your sewage treatment plant shows up every morning. Okay? We have public health departments that identify epidemics and try to suppress them. We don't have, the list goes on and on and on of all the things that we pay for on a day-to-day basis that make it so that we're not on this list. Okay? Every time I hear somebody complain about taxes, I think about that list. Okay? And how much safer my life is and how many fewer disability-adjusted life years that I see lost around me. And, you know, obviously dailies are kids, people's families that have been lost for life. Okay? It's a big deal. In our country, the loss of a child is a very uncommon, noteworthy front page of the newspaper event. In third world countries, you can't swing a chicken without hitting a child that's at risk for dying. Okay? It's common. Getting out of childhood is half the battle. Let's see if we can get one other thing about smoking you need to be aware of. Smoking is more than just a cause of other illnesses. There are direct effects of smoking that make it part of a lot of other troubles that you wouldn't suspect. My favorite is a review article from Family Practice News. I've got copies of this if you know any smokers. The title of it is Smokers with Low Back Pain Must Quit to Alleviate Their Symptoms. There's a strong relationship between regular smoking and chronic pain. It affects how well the medications work. It affects how well things heal, so people actually have more sources of pain. And I'm sure most of you can probably think of the smokers that you know in your life and how achy they are. If they quit smoking, their pain actually improves. It's just another payoff. So let's ask a couple questions. So what can we do about this? What's the kind of take-home message here?
When you're talking smoking, what about
Now, this new generation that these kids that always have a chew.
Oh, yeah, any tobacco.
Any kind.
Oh, yeah, yeah. And basically, they, you notice up here, it didn't say smoking. It said tobacco use.
Okay, that's why I was,
Yeah,
okay, just in
including,
general.
and don't get me started about the mess of chemicals that comes out of those electronic cigarettes. Oh,
Not so
it is
saying
probably
the new thing,
scarier than
yeah,
what comes
yeah.
out of a burning cigarette. When you look at what they have to do to stabilize the nicotine in solution and the stuff they put in there, you'd really rather live in a chemical plant. So,
Madison right now.
we've got this healthcare system, okay? What can it do? Well, if you ask the Institute for Healthcare, did everybody get one?
Yeah.
If you ask the Institute for Healthcare Improvement, they offer what's called the triple aim. They want us to have high levels of quality and patient satisfaction. They want people to be happy with their healthcare. And that they want a quality outcome with quality, measurable quality. They want improved health outcomes where people actually live longer and healthier lives. And they want it to be affordable. But I will say also that in order to do that, we have to provide access. That one of the most important variables in life for health is access to a primary care provider. Everybody get one? Oh, you got one? Okay. Is access to primary care provider is one of the greatest variables. And primary care is there because we're the folks, and we'll talk about this a little bit, that sit in the middle. Everybody, you'll find that we are not very sexy as far as health systems are concerned. When was the last time that you ever saw an ad from a hospital that says, come see our family docs so that you never need our cath lab? So that you never need, so that you won't need our dialysis unit. So that you won't need our bariatric surgery program. So that you won't need, I can go on and on and on. You know that this is not how we sell healthcare here. And so access, but particularly access to primary care is central and critical to feeling well and being healthy. It's thinking. Now it's going to go too. So, what can your family doctor do? Well, the most important thing, everybody thinks of their doctor as being where they go get pills and prescriptions and get things lopped off and when they go to them when they're sick. But I will put it to you, the most important thing your family doc does for you, as far as your health, it's all in your handout, by the way. As far as your health, is to develop a collaborative therapeutic relationship with their patients by which a healthy lifestyle is promoted and you have a guide and navigator through your healthcare system. Because there are opportunities you will have in the healthcare system that you should not take. There are treatments that are available to you, there are medicines that are available to you, there are evaluations and testing that is available to you that you should not do. And you need somebody who can cut through the hype and the recommendations and the suggestions and say, is this really worth my while in the big picture? You need somebody to make absolutely sure that by whatever means, whether it's lifestyle or whatever, that your blood pressure is under rock solid control, that your blood sugar is under control, and that your cholesterol is under control. These are three things, by the way. If they're wrong with you, you feel okay. This is not, I'm feeling sick, go to the doctor, feel unsick. This is, I feel okay, go to the doctor, be told you're sick, here, take some pills or get some exercise or whatever. This is a different view of healthcare than most people have. This is not, you're not burning down right now. But you're gonna. So you go see the doctor so that they take care of these asymptomatic diseases, these diseases that have before they hurt you. Okay? These, by the way, these are in order of importance. Immunize. We live in an age in which I have never seen measles. Been a doctor for 35 years, I've never seen a case of measles. That is wonderful. 20 years ago, every year at least, I would put 2 to 3 children in the hospital with a infection around the eyeball called paraorbital cellulitis. And they'd go on with IV antibiotics. It's occasionally eye-threatening and sight-threatening. And I'd put one patient in at least a year that had an infection of the brain called meningitis. And I would put at least one child every couple of years. I'd see one child in the emergency room on death's door because of an infection in a little flap that goes over the airway called the epiglottis, and I would have to do an airway and intubate them and all this stuff, and it was the worst thing in the world you can imagine. And I haven't seen that in 20 years, and you know why? Every kid gets a Haemophilus shot. Haemophilus influenza. Some of you probably really haven't heard about it. We just do it with all the immunization series. But I used to watch kids that never talk right again, can't hear again, walk funny, because they had Haemophilus influenza meningitis. It doesn't happen anymore. And I've seen that change in my lifetime. Okay? So, you can go on and on about it, but for adults, make sure you've completed your primary series. One thing you never want to do is give me I've seen one case of tetanus, I never want to go there again. Okay? Get your pneumonia shot. Make sure your tetanus and pertussis is up to date. Make sure shingles. Immunizations, as far as bang for the buck, that's one of the major functions of family docs. Notice I haven't talked about prescribing medicine yet. I haven't talked about taking care of acute illness yet, because it's not as big a deal. We do diagnose and treat acute problems, and that's fine. We're there for that. When your ear infection happens or your sinuses get infected or whatever, we're there for your ulcers and all that. But if your doctor takes care of your ulcers and also tells you about the relationship with your smoking and your alcohol intake and the nonsteroidals you take for your sore back because you're overweight, they're giving you the good stuff off the top shelf, not just giving you the medicine to shut down your acid secretion. You must invite your healthcare providers to tell you to live differently, or they'll get tired of trying. We're human too. Okay? And a lot of doctors don't do a lot of this stuff because they don't think it's worth their time. But it is the top shelf stuff. It's what works. And then we do prescribe medication and do all kinds of treatments and procedures and things. And those matter. It's important to have people to do all that stuff and then to use it as little as possible. Okay? You want it there. But you don't want it to be your healthcare system. Your healthcare system should be to prevent all those bad events that are dealt with. And there's plenty of lightning strikes out there. There's plenty of things that are going to get you anyway. But prevent what you can prevent. So, what about health screening tests? Okay? Because this is a little interesting. And this is a PET scan which shows the tumor in the right upper part of that guy's chest, okay? And it's a very attractive idea. If somebody were just to look at me in the right way, or order the right test, they could catch whatever I'm going to get and keep it from happening. That would be a great idea. Well, let's look at that. So, what would a good screening test be like? What would the perfect screening test be like? And that doesn't exist, by the way. But what would the perfect screening test be like? First of all, whatever you're testing for would be very common. Because if you're looking for a rare test, the chances of an abnormal test being something else other than that disease is great. But if you're looking for a really common disease, a positive result is likely to show you the disease you're looking for. Okay? And not only that, if you find it, you can do something about it. For instance, there is a brain tumor that almost never goes well, called glioblastoma multiforme, okay? An early diagnosis of glioblastoma multiforme just means you live longer knowing you have glioblastoma multiforme. It doesn't really change when that end is very much, okay? And we can all think of examples like that. For most folks, pancreatic cancer is a bad actor and it's not going to go well, okay? There's a small number of exceptions, but that's real. So we also want to detect something we can get rid of once we find it, right? We don't want to just find out we're sick earlier and then live longer thinking we're sick, right? Okay? The test for the disease must be sensitive. In other words, I don't want to, if I'm going to go through the bother of a screening test, I don't want to say I don't want to say I'm normal, it's normal, and it actually is abnormal. I don't want to miss stuff. The test must be safe and acceptable. I mean, we could, if we wanted to do a screening test for, say, a really tough problem like cancer of the ovary, I suppose we could just set all the women up for laparoscopy, and we go look around in their bellies and see if there's anything growing on their ovaries. But think of all the risks of that. So we'd end up hurting more people with the test than we would be preventing by finding something early, okay? The test must be accessible and affordable. Not only that, so that everybody can have it. I mean, just screening a small portion of the population is a nice idea, but it really doesn't help you very much when you're really looking at decreasing the frequency of disease. But not only that, the intervention that follows must also be affordable and accessible in some way. Because the worst thing is to find out somebody has a really bad problem and then say, well, it costs this, and they say, well, I don't have that. And now they walk around knowing they got a bad problem that's going to get them. And they don't have access to the treatment. Unfortunately, we live in a world, or a country, particularly a state, that has chosen to turn their back on a lot of people who need health care. And then in the big picture, you want more people to be alive because you've screened everybody. Okay? And this is a tough one for some of our current screening tests. You have to know about the concept of false positives. For every test, you're going to have some people who have an abnormal looking test that requires evaluation that really isn't the disease you're looking for. Okay? I don't care what it is. All tests have some false positives. And there's a problem called lead time bias. Oh, I'm so glad they caught that early, when you know darn well you haven't changed the endpoint at all. And all you have is a situation where now you know you're sick longer. The reason I'd say that is that there are some tests that say, and I'm going to use an example, mammography has extended survival after the diagnosis of breast cancer. And statistically that's true. The problem is we've started detecting a disease that is so early that of course they live longer. Because instead of detecting it a few months before they die because they get a big lump, we detect it 6 years earlier from something that may or may not have progressed. So some of these screening tests get shaky as far as their ability to actually improve outcomes. Oh. So how do some common screening tests measure up? First of all, I'm going to talk to you about the ones that nobody argues about, okay? And if you haven't had these tests, think about it. We do a lot of screening for common medical problems like glucose, lipids, thyroid. We look for hepatitis C, particularly in baby boomers. We look for HIV screening, even in people relatively low risk. And we find all these things, okay? So if somebody wants to offer you screening for these problems, take them up on it at some point and know what's happening. Because if you wait till these diseases are symptomatic, a lot of the water's under the bridge. Get screened for colorectal cancer. This is unfortunately, when you go back, remember when we talked about the test being safe and acceptable? Well, this one is kind of unacceptable. Okay, I'm sorry, it's the way it is. But because colorectal cancer screening is looking for pre-malignant lesions, you're looking for polyps, little doorknobs, fleshy doorknobs that grow out into your colon and then over time get turned into colon cancer. You lop out the polyps, you never get the cancer. In fact, I would support the idea that they stop calling cancer cancer of the colon. I want them to start calling it cancer of colon polyps. And if you don't have any polyps, you don't get colon cancer as a rule. There's some very rare exceptions, but the reality is if you get screened with colonoscopy or you find out the polyps, by the way, aren't built very well so they bleed. So they pick it up using a test for blood in the stool. Okay, that's the other way to pick it up. But get screened for colon cancer when your doctor talks about it starting at age 50. Okay? It's a real deal. And it works. And it's been shown in population studies to have fewer people die of colon cancer and people live longer. It's got great data, okay? It's unfortunate that Papa Niccolo doesn't have a big statue built or constructed in his honor somewhere in the world. But Papa Niccolo, that's who pap smears are named after, has saved more women's lives than any other human being who ever lived, by far. Picking up cervical cancer by looking at the pre-malignant lesions of cervical cancer, abnormal pap smears, has prevented so much disease. This used to be more common than breast cancer, cervical cancer. We just don't see it very much anymore in screened populations. You get pap smears, you don't get cervical cancer as a rule. Real big deal. If you're not up to date on your pap smear, get up to date. Past a certain age, you don't get them anymore. The recommendations have changed. They've gotten more complicated a little bit, but at least touch bases with your primary care provider and says, am I up to date? Am I okay? Am I where I am in life? For all women, make sure you know where you're at and whether you still need to be screened. Still, bang for the buck, no question. Then things get a little foggier. So consider these tests in context. Mammography is a bit of a problem because we used to diagnose breast cancer by somebody coming in and saying, feel that? Yeah, okay, little rock, little hard, little lump there. So somebody figured, well, there are changes in the breast that occur before you can actually feel that lump. And there are. And we can pick those up on x-ray, that's mammography, and we do that. The problem is, we're unsure whether all of those areas that are in the breast that look abnormal that might turn into a lump someday actually are going to turn into a lump someday. Or are they on schedule to turn into a lump when you turn 140 and you're going to get hit by a bus when you're 88 and never get a chance to become a problem? It makes mammography difficult to know what to do with this, okay? There's data, again, that women who are detected by mammography do live longer after diagnosis. It's hard to sort out how much of that is lead time bias, and we talked about the delay that now is longer between the time you find you have something and when you die of it. And also whether we've created more disease by detecting these little cancers or changes that never would have gone anywhere. The problem is nobody's willing to do the real study, and the real study is to randomize women to one group to get screened and one not to get screened, and count them in 20 or 30 years, okay? It's a really tough thing to walk back to where we can ask the questions we actually need to answer. Now, we get pushed this way, and it's appropriate for family histories. If you're worried about it, if you have a history of prior lumps and all that stuff, it pushes the equation towards screening. This is something to negotiate with your physician. PSAs, great idea. This is a hormone that's made by prostate. When you have a lot of prostate, you got a lot of PSA. When you got a little bit of prostate, you have less PSA. And prostate cancer leaks lots of PSA. Let's screen men. Let's get all the ones with high PSA. Let's go find their lumps and lop them out. Well, the problem is, picture of the lopping out. And that has problems. And if you're doing that to some little lesions inside somebody's prostate that never would have gotten big enough to cause trouble, because prostate cancer is actually not that big of a deal until it gets out. And once it's in your bones, it's about as bad an experience as I can imagine for a cancer. It's really, really nasty, okay? I have nothing good to say about prostate cancer. But what I can tell you is our attempts to pick it up earlier so we can get rid of it by using PSAs has not succeeded in improving outcomes. And they've tried to show that again and again. It's a really tough problem. Same thing, bad family history, lots of concerns. It would put your mind at ease to get a normal one. Okay, I can go there. I still order PSAs when, after I've talked to people about it, and they say, I still want to be screened, I'm okay with that. but it's a tough one. You'll see recommendations for smokers for chest CTs to check for early lung cancer. That has a small but real benefit. Looking for abdominal aortic aneurysms, small but real benefit. The better answer is to do what? Stop smoking so you don't need to test, right? You'll have a lot of talk about checking for all kinds of genetics for cancers in families that have a lot of cancers. And as long as you're very, very picky about who you test and who you don't, this doesn't cause too much trouble. But make sure you meet all the criteria for needing screening before you have this testing. Because talk about trouble, there's all kinds of untoward events that happen to women, particularly women, who have this testing as far as getting things lopped off. Okay? I want you to take all the ads that you see in the newspaper to come and have the ultrasound of your carotid, or your arteries, or your CT. You can go to malls in California and they'll put you through the MRI. Cash on the barrelhead. CTs. I had a patient come to me. He says, I went and I had my CT scan and it shows cancer all over my spine. You know, I just wanted to talk to you about how we're going to take care of, you know, what kind of trouble you're going to have and all this, and you know, how you're going to help me out. I already talked to my family, and you know, they understand it's a pretty serious situation. And so he had the films under his arm, and I walked up to my radiologist and I said, I looked at him, I don't see anything. What's going on here? And what was called cancer in his spine, and he had back pain, so he was sure he had something, was actually a normal variant, normal anatomic variant in the blood vessels. And I got all kinds of people that are going and getting this all kind of screening who've never had a stroke, and they pay $500 or whatever it is, cash in the barrelhead for their scan. They come in, they say, I've got a narrowed artery in my neck, let's go get it fixed. And I say, one, it's not tight enough to where the risk of the surgery is less than the risk of keeping your narrowed artery. And two, what we really need to be talking about is what I would have talked to you about, even though you don't have this $500 scan, and that is, let's talk about your smoking, your diet, and your controlling your cholesterol, and controlling your high blood pressure. And if you want to give me $500 to do that, I'm okay with that. It'll save you money. We'll all end up ahead. Don't do direct consumer screening. It almost never helps. I don't care about the testimonials either, okay? Waste your money. Now, if you want to get in the weeds on this, for any screening test, I'd only scratched the surface of some of these to give you a flavor of what we look for in screening tests. This website is on your screen. This is the U.S. Preventive Services Task Force. They are the people who look at all the data with regards to all these. There are pages of every single screening test you've ever heard of. You can click on it under the patient area and it gives you a lay language explanation of every test, what it's proven to do, what it hasn't been proven to do, and whether they recommend it or not. Now, the only problem is, on your copy, there's a space between B and R. Don't do the space. That's a misprint, okay? But feel free. This is if you really want to, like somebody says, I want you to have such and such a screening test or whatever. Get on this site, it'll give you the latest evidence in lay language. There's a patient section and then there's a doctor talk section, okay? So that's screening. And when somebody recommends a screening test to you, ask them the questions. You know, how much difference does this make in my life? So finally, what can you do? Well, none of this should be a surprise at this point. Do not use tobacco in any form. Okay, I mean, it's just absolutely the worst thing you could do, and if I get somebody to quit smoking, I have done more good than everything else I'll do the rest of the day combined. Guaranteed. Be physically active for at least 30 minutes every single day. Now, what do I mean by that? Well, I don't mean running marathons. If you can do this for 30 minutes, do that for 30 minutes without interruption. It's kind of an important idea. We're not talking, because I have people who tell me, oh, I garden. And gardening's good, it's better than sitting on the couch. But it doesn't really count for this kind of sustained exercise. You're actually creating a very low-level physiologic stress on your body that has all kinds of positive responses in how you metabolize glucose, how you secrete neurotransmitters that tighten up blood vessels and cause high blood pressure. It starts chewing into your stored fat so that you can lose weight and start transforming it to lean muscle mass, which is healthy for you. And I'm saying at least 30 minutes a day. But if you can only do 10, then do 10. But that means a week from now, you're doing 12 or 15. And it's sustained. And it's what pace you can do. I don't want people going out there and hanging over things and sweating and getting so short of breath they can't do it the next day, or getting so sore they can't do it the next day. The idea is not how hard. The idea is without interruption and sustained, okay, and at a level you can tolerate. Now, I know very few people who start walking half an hour a day who are still walking half an hour a day a year later. They're out 45 minutes or an hour. They're going twice as fast. They're doing other stuff. Maybe they're doing their first 5K. I don't care. But you gotta start where you're at and move every day. And that movement is medicine. Okay? It is more potent than any pill I prescribe. If I can get you moving, I can make you healthy. You can make yourself healthier. Eat a healthy diet that emphasizes vegetables, fruits, and whole grains and minimizes animal fats, sugar, and salt. No surprises here. Okay? I know it seems like moralistic, this is what you ought to do message. The data is overwhelming, okay, that this is true. Maintain a healthy weight, which is related to the two above, right? None of these things are islands. You don't exercise as much if you're a smoker. You just can't, doesn't feel like it. Only drink alcohol in moderation, if at all. Okay? Moderation has actually been defined and figured out. 1 a day. And when I mean one is 12 ounces of beer is equal to 5 ounces of wine is equal to 1 ounce of liquor. Okay? For women. Men, probably 1.5. Size matters. None is not clearly worse in any way than 1. What I mean by that is you always hear about the health benefits of red wine. There's probably something there, but not enough of a difference where if you just decide I'm just not going to drink at all, that you're going to notice much. Okay, but there are mild advantages of red wine. When driving, wear a seatbelt and don't drink alcohol. When riding, wear a helmet. Okay? There aren't any big surprises here, but I think the message I wanted to convey tonight is that when doctors talk about this, this is the top shelf stuff. This is not what you do in addition to everything else. This is first. This is where the bang for the buck is. And we're not just wasting our time and your time by bringing it up. I'll never forget walking out in the parking lot, and I was dressed kind of like the way I am now, so I didn't look like I worked there at the office. And I came out behind these two folks that were walking kind of slowly, and one of them was visibly angry. And he says, I come in here to get this whatever taken care of, and all he wants to talk about is my smoking, and the fact that I don't exercise, and the fact I'm overweight. I've wasted my time. He's going on and on and on. He's talking about one of my residents, okay? And I'm so proud. It's kind of like when your kid gets dropped off at 11 and all of his friends get picked up at midnight. Okay? All right? You know, you're just proud because somebody tried to do it right. Took the time and all the rest. And this is what I want you to invite from your doctors as you go through your life. So, with that, I think, Maddie, you'll like this part. That's Matt. That's Emily. That's me trying to do the same thing.
Oh, yeah, that's flexible, right?
So questions, discussion. Yes,
Oh, no, I have a question with regards to the healthy weight, knowing we
Yeah.
had the whole healthy discussion
Yeah.
at the beginning. And news programs always make me scratch my head because I wonder where they're getting their information. But they say there are some people who are somewhat overweight who are more healthy than those people who are physically fit. And I don't know if it's because of the fact of the wear and tear that the physically fit are putting on themselves in comparison to the person who is healthy but is a little bit on the heavier side because of the heart status and the cholesterol and everything else.
the way I approach that is, first of all, I used an example. Everybody's heard Charles Barkley, proud to bound and rebound.
Yeah,
Right?
Sir Charles.
Big, yeah, who is morbidly obese by all criteria when he was the NBA most valuable player. I watched him play one day. I never saw him sit still. He's an absolute aerobic animal, okay? He's made of solid muscle, or was at that time when I saw him play. I have a body mass index of 30. I'm obese. Okay? 2 months ago, I was in the American Burger Binder 54 kilometer cross-country ski race in Wisconsin. Okay? I probably have a different looking lean body mass. So I don't think about weight as much as I talk about body composition. And the reality is that you will gravitate toward the weight that matches your level of activity and your diet. If you are weighing more on the same joints, you're going to feel worse. So it's almost always better to be lighter. And I feel better when I'm lighter. My weight goes up and down, I don't check. What I concentrate on is what I can do. And as long as I can go out and be active for hours on end, my body tends to feel good, and it's about right. But it's hard to believe anybody feels well if they meet criteria for obesity and they're exercising once, maybe twice a week, and they're eating a liberal diet rather than a diet that focuses on healthy things. So concentrate more on what you're made of rather than how much.
Okay.
And so volume of aerobic activity is the key, and eating a healthy diet. I'm a vegetarian. People silently wait for me to waste away. It hasn't happened yet. Okay.
I work with vegetarians.
Yeah, right. I mean, you know, but the point here is that you do, when they say, notice I didn't say lose weight, it said maintain a healthy weight, okay? What you feel good at, what you can walk up hills with, what doesn't leave you bent over and gasping and thinking like you're gonna pass out when you do stuff. Go there, okay? The weight will happen, secondarily. And if you're gonna try to lose weight, don't weigh yourself more than once a month. You'll do this all the time and drive yourself nuts. Okay, about once a month. But the number doesn't matter as much as what you're made of. And if stuff's hanging off, and you don't have good tone, and you don't have the muscle mass you want, go fix that. Whatever weight you're at, if you feel good, you can walk up hills till the cows come home, and you can do what you want to do, and your joints don't hurt. That's the other kind of fallacy. Well, people tell me, I can't exercise, I hurt too much. I says, no, you hurt because you don't exercise. If you talk to people, do pain scores, people who exercise regularly hurt much less than physically inactive people. Much less. It's not even close, it's an inverse thing. Get moving. 45 minutes, an hour a day, do more. Keep going. That 30 minutes is a minimum. But get moving. Yeah, I can get one message out there. I don't want to see, if I'm not going to see you for 3 or 4 years, it's usually because somebody took on a lifestyle change and they don't need me much anymore. And that's good. What other questions? Yeah.
They went to the doctor and they said something about a Hep C shot.
Mm-hmm.
They said something about at my age I should do it, and why? And do you think it's
They
important?
probably wanted talking about just screening for hepatitis C, blood test to see if you have the antibody. And that's recommended for everybody, my generation, older or whatever. I'm 58, I think if you're the line somewhere around 50, because we have the highest incidence of hepatitis C in our society, and screening us makes all kinds of sense. And now you can treat it, so it makes it reasonable. Again, don't do a screening test for a disease you can't fix.
Yeah.
Okay, but this is a disease now we can fix. So there is a recommendation out of CDC that you be screened once to find out if somewhere back there. And this had something to do with, I don't know, dorm life, I don't know. What other questions? Any other questions? I don't even know where we're at with time. Oh geez, we're got time. Anyway, any other questions? Yes?
I asked about the shingles shot,
Yeah,
and I don't know if I had the chicken pox, and I don't
Right.
have anyone around to tell me if I had them.
yeah.
So,
Did you live on an island or on an isolated range?
no.
You had chicken pox. It's actually rare. It's hard not to catch chicken pox. Chicken pox is incredibly efficient.
Yeah.
In fact, I think my kids were the last generation where we actually sent kids to chicken pox parties to make sure they got it.
Yes.
Get it over with when we had time and it was convenient. This was before the chicken pox vaccine, okay? And the reason we did that was, part of it was, I want you to get it when I've got time off or whatever, and it's more convenient and all that. I don't want you getting it during Christmas, I don't want you to get it here and there. So it was kind of like self-control of our schedule. But when I was in Sheridan, Wyoming, I used to practice in Sheridan, Wyoming for about 8 years, and I had one cowboy, 27-year-old guy come in who got chicken pox. And he had lived in an isolated enough place out 80 miles north in southern Montana where every time chickenpox came around, he never got it. Okay? And he got it when he was 27, got chickenpox pneumonia, and he was on the ventilator for 2 weeks. He's a vigorous, strong, powerful guy, bull rider and all this stuff. And he came in down near died on me. So, if you're going to get chickenpox, get it as a kid, okay? Okay. Or get the shot, okay, which is probably going to eliminate a lot of the troubles. But shingles is the reemergence of that virus. And unless you were in a relatively isolated place, you almost undoubtedly did. You can actually go get a titer to find out if you did have chickenpox or not. For most folks, they're just going to give you the chickenpox vaccine. Okay. And so having seen my share of shingles,
You'll be glad
it's
to
my
get it.
turn, I get the chickenpox vaccine. Okay? It's not a good deal.
So is there any problem getting the chickenpox there? I mean,
The
the
shingles?
shingles vaccine,
No.
if you haven't had chickenpox? That's what I thought, so
No.
you might as well just do it.
Yeah.
I think you're asking that you'd be 60 years old.
Yeah, you gotta be a certain age, otherwise it doesn't make much difference.
I
So if you're unlucky and you get shingles,
Well,
when you-
when you reach 60,
yeah. So,
you
that's gonna be one of my gifts to myself when I turn 60. I'm gonna go get my shingles shot. I don't wanna have any, I don't want any of that.
Why is it 60?
It had to do with, one, that's what the studies were done in on efficacy, and two, we don't know for sure how long it lasts, and that study, the studies were done in that age group, that's part of the deal. And then also the bad outcomes with shingles get worse with age, and so it was kind of a balancing act. I mean, obviously, well, why don't we just give them at 30, why don't we give them at 40? Well, because there's always an opportunity to get shingles at earlier ages, but it does do this. Shingles does that, and the cutoff point that they decided on was 60 years of age. Okay, I don't know the whole science on that, but it's usually some sort of balancing act
It
between
doesn't
cost
hurt.
and effectiveness and duration of effect.
So if the duration, I mean, if it wears off over time, do you ever need to get another one? If you-
Well, they don't know that yet.
Oh, okay.
Okay, it's kind of like, you see, that there's this thing waiting out for us out there that we don't know what's gonna happen, and it has to do with the chickenpox vaccine that's given to kids. Right? I have this, having had, you know, Rory come in at 27 with chickenpox pneumonia, I never want to see that disease very much, okay? That's a bad disease. Adult chickenpox is a nasty actor. And so we're pretty sure that it's sustained. So far, the thing's been given since the late 90s, and we've not seen any breakthrough late with bad cases. But I always worried about that when it first came out. Same thing with shingles, you know. You could theoretically say, but we're gonna have to wait for the experience to say, oh yeah, it's starting to come back. I think you've seen this with pertussis vaccine, for whooping cough vaccine, where before we used to give it to kids and we never thought about it again. But then we started to see reemergence, waning of immunity later in life, and now what do? We give a tetanus shot that has pertussis in it to give boosters to all the adults every 10 years through their lives. And that was a response to this experience. None of the things I'm saying will be true forever. Not one of them. Everything's evolving. The knowledge changes, and I suspect some of the things I've told you tonight are going to be wrong eventually. So you got to kind of keep track, and that's one of your jobs, your primary care person, is to kind of, okay, this is what we do now. What we do for blood pressure has changed in the past few years. What we do for blood sugars in some groups has changed in the past few years. It's, we swim in this all the time, and you just got to expect that it's going to, you know, never look at your doctor and say, oh, great, now it's all different. Well, that's great. Now somebody knows what the latest information is, and we do turn the ship every now and then, go a different direction. Yeah?
I never take the flu shot,
Uh-huh.
and I noticed it wasn't listed up there, but
It
I
should have.
noticed pneumonia was listed,
That's an
and
omission.
I've never
That's an
considered.
omission. That's on my part. That would be on my top list. And I'll tell you why. So the deal is, see, one of those people who get a really pretty significant reaction to flu shot about half the time. When I get my flu shot, I usually get it on Friday, because I know Saturday I'm gonna start having some sweats and some chills, maybe a little diarrhea, a little bit of sore throat. I'm gonna feel like laying around all day, and then by Sunday I'll start feeling a little better and I'll be ready to go back work on Monday. So I always schedule on a weekend where I don't have other things going, and then I get my flu shot. That's just my experience, and it happens about half the time I take a flu shot. So one year I said, heck with that. I'm not gonna do that to myself anymore. So I didn't take a flu shot one year. And, you know, we hang around a lot of sick people, in case you wonder.
Yeah,
I got documented influenza A. Boy howdy. I've taken a flu shot every year since. I worked in Sheridan for about 8.5 years, and I bet I took maybe 5-6 days off of work during that whole 8.5 years. One day was after I broke my elbow. The rest of them were that time I got influenza A. I felt like I'd been beaten with a stick. Okay? So, flu shots. I should put it on the line. In fact, I'm gonna add that when I get done. If I ever use this again, yeah, definitely. It's, you just don't wanna go there.
and pneumonia, also pneumonia.
Yeah, it can be a bad actor, but influenza just hurts. It just hurts. It kills a bunch of people too, but it hurts. So no, that's an omission. I didn't wanna make this a comprehensive, everything you wanna know about every shot, okay? Because that's a whole talk. We can talk about immunizations all night. But I wanted to give you the overview of what to expect from medical care. That's kind of what this was about, is what's your role, what the role of the healthcare system is, and how do you balance that and stay as healthy as you possibly can. That's, I want to do the top shelf stuff.
So is your question, Patsy, should you have a pneumonia shot?
Well, sounds like I should have a flu shot.
Oh, yeah. Until you've experienced influenza, it doesn't make sense. Okay? Makes all kinds of sense once you've had influenza, or you've taken care of enough influenza. Influenza is not the flu,
Well, but
okay?
But it is for influenza then.
Yes, it is. Okay, so just so you know, we call it the flu shot, but we call a lot of things flu.
And
We
I-
call a lot of colds flu. We call a lot of GI bugs the flu.
Yeah.
Flu has become this generic term like Kleenex, okay? Influenza, which is what the shot prevents, is a serious systemic viral illness that lays people on their backs and kills a bunch of them. We've had people die of influenza this year, okay? It's a very different animal than what a lot of people call the flu. So no, it won't prevent all your colds and sore throats and diarrhea or GI bugs, but it will fairly reliably, not completely, prevent influenza. Why it doesn't is because people are out in Australia and Asia and all the rest measuring influenza viruses right now in an effort to predict what influenza strain will make the rounds next year. They go to the factories here in the next month or two, and they start making antibodies to just those strains that are out there floating around. New strains show up, old strains go away, stuff comes out of the blue, so it doesn't always work. Okay? Or they change, they mutate between now and then. But it's their best shot. And that's what makes the influence. Usually it covers 1, 2, or 3 strains depending on the year of what's floating around. So it is an inexact science. But I can't say anything good about influenza. It just hurts. Okay? Yeah.
Is it true the researchers really get their top 3, what they think is
Yeah,
going to
yeah,
be
yeah.
prevalent?
It's an odds game. It really is. And then you gotta get this stuff to grow in the lab,
Eggs and-
and then you gotta develop the antibodies to it. It's actually very uncertain. It's a much messier process than you'd think. It isn't like, square peg, square hole. It's not like that. It's uncertain, but it's a lot better than everybody getting influenza, a lot better. Our hospital would be full of influenza if we didn't get flu shots.
Are there,
Yeah.
oh, I'm
Sorry, that was it.
Are there more, how many manufacturers? I know there were 2 primary, and then one had problems a couple,
Yeah,
3
and then
years
they go out
ago.
of business, and then
So,
they go back in. And
Sanofi and somebody else.
I don't know who's active
Okay.
right now. That's one of those things where in a lot of countries, those are all government-run factories. They just do it in-house and all the rest, based on CDC data. By the way, CDC tells everybody else in the world what to do. They listen to the CDC, so they don't have to run a CDC themselves.
People will say
Sorry, I
to me,
got-
I had a real bad case of flu, and I'll say, well, did you have your flu shot? Yes, I did.
Right.
And then I think,
And they did have.
that's baloney,
Right.
I'm not gonna bother.
And I agree, they had a really bad viral infection. It could have been influenza that broke through. More likely, by far, it's a coronavirus or any number of other parvovirus. There's a whole list of viruses it could have been.
Thank you.
Yes?
I'm just trying to determine the best time to get it, because there are people who say, well, you
Yeah.
want to get it in November versus getting it in February versus getting it any other time of the year.
Yeah, that's a real balancing act, because you don't want it to peter out in April when it kind of, the new strain floats up on shore. Even if that happens, but you definitely want it on board before the first cases show up, okay? And this is an artifact of living inside. People trade viruses much more efficiently when the windows are closed and they're in airplanes and they're in closed spaces, so that's why it gets worse in the winter, because we trade germs more efficiently. And so I think of, my little thing in my head is, first time I turn my heat on, I better have my flu shot by then. Okay? And because I'm gonna see it first. The first guy who gets influenza in town is gonna show up in my emergency room and need to be admitted to the hospital or whatever. And I'm gonna be looking across the bed at him, so I tend to go earlier. As soon as they come up into September, October. But sometimes they will do the epidemiology worldwide so that they can say this is probably gonna have a later peak, and they'll push it back. And this happened like 3 years ago where they said, we're not going to recommend it until mid-October instead of the beginning of October. Whatever they say, as soon as it's available, I usually get my shot because I don't really see the people, but that's me and my situation. And it's possible I could get a tail end case in April because it wore off by then, but I'll take that chance. A lot of the tail end cases are new strains that have evolved despite the fact that the immunization's out there anyway. So, we're swimming in it all the time. We just try to prevent the most common. Any other questions? Well, I hope this has been useful.
Yes.
Thank you all very much.
Thank you. Okay.